Good afternoon. Hello, everybody. Good afternoon. Good evening. My name is Jennifer Mulwantwa. I am the CEO of the Water Research Commission, and it is my pleasure this day and this evening and somewhere else in the world this afternoon to be on behalf of the Coalition Against Typhoid to welcome you to this session that we're going to have, which is labeled Bridge Over Troubled Water, Improving Water Systems to Combat Typhoid. I am pleased that this afternoon or evening, we will be joined by 4 distinguished speakers from the WASH and infectious diseases community who will present on the public health risks associated with climate change, the importance of establishing safe water solutions, and the impact of climate change has on WASH and infrastructure. Following the presentation by the 4 distinguished persons that I've just indicated, we will then go into a more panel discussion as well as question and answers. But before we jump into the presentations, we have 2 housekeeping rules that I would just like to run by. Firstly, if you have any technical difficulties, please do use the chat box to communicate with us. The same chat box should also be utilized for your questions that will also be run later after the presentation. So you can start interacting with us through the chat box. Also, I am now pleased to introduce our first presenter, that is Dr. Stephen Luby. Dr. Luby is a physician, epidemiologist. He lived in Karachi, Pakistan for 5 years, and also in Dhaka, Bangladesh for 8 years, working with local researchers to broaden understanding of exposure pathways and disease burden of infectious diseases and developing interventions to reduce that burden. In 2009, Dr. Luby was awarded the inaugural Oklahoma University International Water Prize in recognition of his contribution in the field of water supply and sanitation, and he has recently joined Stanford University as a professor of infectious diseases and director of research for Stanford Center for Innovation in Global Health. He has mentored 41 scientists from low-income countries to publish their initial first authored manuscript in a peer-reviewed international scientific journal and has also authored over 500 scientific articles. Welcome, Dr. Luby, and we can go through your presentation now. Thank you, everyone.
This seminar is titled Bridge Over Troubled Water. These waters are troubled for 2 reasons. First, they're troubled because all too often the water available to communities globally is contaminated with human feces. Second, these waters are troubled because progressive climate change is substantially altering the hydrological systems that life on Earth, including human communities, depends upon. So I want to begin this session with a few thoughts on climate change as a driver of waterborne disease. Although the specifics of how precisely climate change will play out in each geographical area is uncertain, climate experts warn us that the accumulation of greenhouse gases will increase extreme weather events. These include floods and droughts. Hirabayashi and colleagues took the time frame 1971 to 2000 as their baseline and considered floods during this time that were the most extreme flooding event that would be expected over a 100-year time frame. They then averaged 11 atmosphere-ocean general circulation models that project water flows in the coming decades to forecast the frequency of future floods in 2071 to 2100. So they projected how many years on average in 2071 to 2100 would elapse before a flood that we would call a 100-year severity flood based on the experience in 1971 to 2000. And so what you can see by looking at this graph is that there's an awful lot of areas here that are in quite dark blue. suggesting, throughout much of South Asia, Sub-Saharan Africa, Southeast Asia, and even in Latin America, in Southern America, we see that what used to be 100-year floods are now more likely to occur every 5 to 25 years. And if you look at the very dark blue areas, we would expect a 100-year flood every 2 to 5 years. So looking forward, we anticipate increased flooding. Karen Livy and her colleagues did a systematic review of the relationships between diarrheal disease and temperature, rainfall, flooding, and drought. And a key finding that emerged from this analysis was that heavy rainfall is associated with elevated rates of diarrhea. And why this is because there's an awful lot of contamination in the environment. In low-income countries, 90% of public wastewater and 70% of industrial wastes are discharged into the environment without treatment. In high-income countries, it's somewhat lower. 30% of wastewater is discharged without treatment. But when we think globally, it's 80% of wastewater that's discharged without treatment. So when we think about our environmental waters, these are data from the UN World Water Development Report, you can see that there are an awful lot of areas, again, in Southeast Asia, in South Asia, and through the Middle East, and again in South America, we see an awful lot of fecal coliform contamination in the rivers and streams in these regions. The area of red there, severe fecal pollution in these surface waters greater than 1,000 fecal coliforms per 100 mLs of water. So with heavy rains, with flooding, environments then, including communities, get flooded with what is actually quite contaminated water. A second key finding from the Levy systematic review was that higher temperatures are associated with elevated rates of diarrhea. And as we all know, July 2023 was hot. It was the hottest month ever recorded. And with climate change, we expect to see more heat. Again, I want to look at a global analysis. So Cook and colleagues looked at change in projected summer total soil moisture at the end of the century, comparing that again to 1976 to 2005, combining 17 climate models. And if you look globally, I just want to draw your attention to all those areas that are brown. Those brown areas are facing between 5 and 20% reduction in total soil moisture. So not only are we seeing more heat, but we're also seeing more dry soil as a result of drought. The areas with hash marks, there's not enough the confidence intervals are overlapping, so those are harder to predict. But we know in the brown areas that we will expect more dryness. And this is a problem because many people are dependent upon walking to fetch their water. Amy Pickering and Jenna Davis did an elegant analysis of 200,000 demographic and health surveys across 26 countries. And what they found was that every 15-minute increase in a round-trip walk time to water source was associated with a 69% increase in child diarrhea in that household and a 12% increase in under 5 mortality. The farther women have to walk to collect water, and it is usually women, the less water is available for various uses. If you have to go very far to get it, you're not likely to use water to wash your hands and dump it on the ground. Moreover, when water's in short supply, households may have to compromise on water quality. So this then raises a theme that is all too common, and that is that poor people are disproportionately affected. Poor communities are disproportionately exposed to droughts and floods. Compared with the non-poor, when poor people are affected by a natural hazard, they use a larger fraction of their wealth and they're at increased risk of mortality. So given these threats, how might we respond to the threat of climate change on waterborne disease? Well, I've tried to present you recent data, but these are not recent data. These are over a century alone, published in the journal. These are over a century old, published in the Journal of Infectious Diseases. And what you can see, going back even to the 19th century, deaths from typhoid fever 5 years before improving water supply were much higher than after water supplies were improved. When water supplies were no longer drawing on fecally contaminated water sources, mortality from typhoid fever dropped by 78%. And of course, typhoid is classically a waterborne organism, but even if we look at total mortality, there was a mean 19% reduction in these communities. Or as Sedgwick noted, for every typhoid death averted, 3 other deaths were prevented. So we've known for over 110 years that this is a good strategy. But when we turn to high-need communities, we find that these approaches are prohibitively expensive. Per capita costs for sewage systems is $300 to construct them, and perhaps even more importantly, $60 in annual operation costs. Traditional sewage also requires a lot of water. 15,000 liters of water per person per year. And when we think about parts of the world getting drier, this seems an awful lot of water to be dumping into the sewage. And in fact, no low-income country city with population greater than 1 million provides universal centralized sewage and wastewater treatment. So it's not just a handful of cities that have difficulty with this coordination because of their particular environment or political constraints. This is such a hard problem that it has not been solved anywhere. When we think about major civil works, they're expensive to build, they're expensive to maintain, and they require steady professional governance to support operations and maintenance. In most low and middle income country cities, there's little appetite for water tariffs that would be high enough to cover the cost of water and sanitation infrastructure. And regular water and sewage, therefore, tends to be targeted to elites, and it leaves out the much larger poor population. In addition to climate change, we are also facing continued population growth. And with population growth and a fixed total freshwater supply, we are also finding a progressive decrease in per capita water availability. There simply is not as much water per person available because there are so many people and the available water is fixed. One silver lining to this situation is that it allows governments to reconsider the value of wastewater as a resource and the value of better treatment of it, and so that there may be further use of that water. So in conclusion, climate change will increase the risk of transmission of waterborne disease. Flooding, higher temperatures, and limited access to water increases the risk of fecal-oral transmitted infections. The poor, whose children are at increased risk of death from diarrhea, are at increased risk from climate change. So what are the key steps going forward? Well, first and most importantly, we need to radically curtail greenhouse gas emissions to limit the amount of damage we do to the climate system. And we also need to focus on improved management of water supplies globally, including a whole of watershed approach with a particular focus on treating wastewater. I hope you enjoyed the seminar.
Thank you very much, Dr. Lube, for that insightful presentation. Ladies and gentlemen, welcome. Just also to remind you, we are in the session at the World Water Week online session on behalf of the Coalition Against Typhoid, where we're looking at the session called Bridge Over Troubled Waters, Improving Water Systems to Combat Typhoid. The next presenter that we have is Dr. Christine Moore. Dr. Moore is the Eugene Gangarosa Professor of Safe Water and Sanitation in the Rollins School of Public Health and the Director of the Center for Global Safe Water, Sanitation and Hygiene at Emory University. She also leads a doctoral program in global health and development. Over her 40-year career, her research has focused primarily on the environmental transmission of infectious agents, in particular foodborne and waterborne diseases. Dr. Moore's research team has conducted surveillance, field and laboratory research in over 15 countries, and this includes studies on environmental surveillance for infectious diseases, diarrheal diseases, on-site sanitation system, exposure to fecal contamination in low-income urban environments, water quality in distribution system, water, sanitation, and hygiene in healthcare facilities, as well as resource settings and fecal contamination on vegetable crops. Welcome, Dr. Moore. Please take it, the presentation. Thank you. Dr. Moore, can you please unmute yourself so we can be able to hear the presentation? We still have got the presentation first slide. Thank you.
Hello, my name is Christine Moe, and I'm very pleased to have this opportunity to participate in this session about typhoid fever, WASH, and climate change. I would like to start with two initial takeaway messages. First, typhoid fever has long been recognized as an important waterborne disease. Historically, typhoid fever was the driving force behind many improvements in municipal water systems, such as the addition of filtration and chlorination. However, in recent years, many of us in the WASH community have become less aware of typhoid fever, and it is often considered, at least in high-income countries, as a disease of travelers. Overall, there has been much less discussion of typhoid fever in the WASH community compared to cholera, but in many low-income countries, typhoid fever is still an important pediatric disease. Historical data from the United States, as well as many other high-income countries, shows the effectiveness of water treatment to reduce typhoid fever mortality. In this slide, you see how the overall death rate from typhoid fever in the United States dropped dramatically starting in the early 1900s down through the 1940s, in parallel with increasing water chlorination in the United States. In 1908, Jersey City, New Jersey was the first city in the United States to begin routine disinfection of community drinking water. And in the figures on the right, you can see similar declines in typhoid fever mortality rates in 6 major cities from 1900 to 1936, in conjunction with the addition of treatment by chlorination and/or filtration of municipal water supplies. So, if we just focus on sustainable treatment of water systems, then we can eliminate typhoid fever, right? Unfortunately, as you may suspect, the situation is more complex. There is an interesting case study from the 1970s in Chile that I first heard about from Dr. Mike Levine that I want to share with you. In the 1970s, Dr. Levine and other infectious diseases researchers in Santiago, Chile, were baffled by the high incidence of typhoid fever among children 8 to 13 years old. And this was true for children from both households with high and low socioeconomic status. Even, as researchers said, among those who lived under apparently nearly optimum sanitary conditions. The researchers also noticed that there was a summer peak in typhoid incidence. At this time in Santiago, about 94% of households had chlorinated water, and 75% of households had flushed toilets. So there was very good access to wash infrastructure. However, further in-depth analysis indicated that although a high percentage of households had flushed toilets, the municipal sewage was discharged without treatment into a local river. Furthermore, during dry summer months, the river was used to irrigate food crops, such as lettuce, cabbage, and celery. The figure on the right shows the river and the location of irrigation canals that were used to irrigate food crops in peri-urban areas around Santiago. The researchers placed more swabs in the river and the irrigation canals, and they were able to isolate Salmonella typhi from 12 samples. The investigators concluded that it was human fecal contamination of the irrigation water that led to contaminated vegetables, which served as a vehicle of typhoid transmission in the community among both low and high-income households. The government responded to the findings of this study by intervening to change farming practices and the use of contaminated irrigation water. It's important to understand that Salmonella typhi is a human pathogen that is only found in human excreta. Therefore, good sanitation and fecal sludge management is critical for keeping Salmonella typhi out of the environment. So, if we have chlorinated water supplies and good fecal sludge management, will that be enough to prevent typhoid fever? We have some information about typhoid fever transmission from outbreak investigations and from case control studies in areas of endemic typhoid fever. These investigations indicate that water and food contaminated by human excreta can serve as vehicles of typhoid transmission. Consumption of raw produce irrigated with or washed with wastewater, as you see in the photos below, and also eating raw shellfish harvested from estuaries contaminated with sewage discharge have been identified as risk factors. However, food and beverages can also become contaminated during preparation and handling by infected food handlers, such as the infamous Typhoid Mary, who was a cook who infected multiple families with typhoid fever because she was a chronic carrier of Salmonella typhi. Street foods and even dairy products such as milk and ice cream have been implicated as risk factors for typhoid fever because of poor hand hygiene and food hygiene practices. Finally, I want to share the results from a study that we did in Kolkata, India in 2019 to 2020 to examine how adults and children get exposed to fecal contamination and Salmonella typhi in their everyday lives. We were able to complete the study in 2 neighborhoods just before the pandemic hit Kolkata. Using our SaniPath approach, we collected information on a range of potential fecal exposure pathways by asking adults and children about their everyday behavior using 3 types of surveys: household, school, and community. We also conducted structured observations on childcare practices and food preparation practices in 48 households. And we collected a range of environmental samples from the public domain and within the household, including samples from open drains, surface water, bathing water, drinking water, flood water, raw produce, street food, swabs from public toilets, and soil samples. And we tested these samples for indicators of fecal contamination using E. coli and somatic coliphage. We also tested them for human-specific fecal contamination using Bacteroides phage culture methods, and specifically for Salmonella typhi by enrichment and quantitative PCR. We combined the behavior data and the environmental contamination data and used Bayesian analyses to estimate risks of exposure to fecal contamination. These tree plots indicate that there were high levels of exposure to overall fecal contamination in the environment in both neighborhood 1 and neighborhood 2. The dominant pathways of exposure for children in these two neighborhoods were contact with flood water and open drain water, and consumption of contaminated produce and street food. There were high levels of fecal contamination in several environmental pathways as measured by E. coli concentration in the environmental samples, especially in drains, in raw produce, in surface waters, and in street food. Despite these high concentrations of E. coli in the environmental samples, we only detected Salmonella typhi in surface water samples from both study neighborhoods and in soil samples from one study neighborhood. We also detected Salmonella typhi in food preparation areas in 3 out of 50 samples from 48 households. These samples were collected during the structured observations. In conclusion, prevention of typhoid fever, like many other wash-related diseases, requires a sustainable, comprehensive approach. We need to prevent contamination of water sources with human excreta. Water treatment is a critical prevention measure, but it may not be sufficient to prevent typhoid fever if it is the only wash intervention. As we saw in the case study in Santiago, it is also important to have good sanitation and fecal sludge management. Discharging untreated sewage into waterways used to irrigate food crops can lead to widespread disease risks. Finally, it is also necessary to have good hand hygiene and food handling practices so that food does not become contaminated by infected food handlers. So part 2 of my takeaway messages is that typhoid fever is not only a waterborne disease, but it is also related to sanitation, fecal sludge management, and hand and food hygiene. We are fortunate to have effective vaccines against typhoid fever, but we also need sustainable and comprehensive wash infrastructure and practices. I would like to close by acknowledging the efforts of many people at Emory University that worked on our study in Kolkata, and our great collaborators at the National Institute of Cholera and Enteric Diseases in Kolkata, and our collaborators at the University of Brighton. We are grateful for the support of the Bill and Melinda Gates Foundation that sponsored this study. Thank you very much for your attention.
Wow, thank you very much, Dr. Moore. I think we really have got a complex situation with us there. We have now thus far been able to note that typhoid is not just a waterborne disease, and that climate change does drive contribute to driving its presence. So what can then we do about typhoid? Next on our list of distinguished presenters, I'm happy to present Dr. Eunice Ubomba Yaswa. Dr. Yaswa holds a PhD in microbiology from the Royal College of Surgeons in Ireland and an MSc in medical microbiology from the London School of Hygiene and Tropical Medicine. Dr. Yaswa area of expertise lie in microbiological water quality and how that ultimately affects public health. She is a research manager at the Water Research Commission of South Africa, and she manages a portfolio of projects that deal with the thematic areas of source water pollution and protection. She also deals with issues related to water-related human health and WASH activities. She supervises PhD and MSc students registered in a number of universities. She has also co-authored a number of publications which involve water research as well as popular articles which speak to a variety of areas in the water sector. She sits on a number of editorial boards, including technical committees, as well as working groups involved in water, health, and environmental issues. Welcome, Dr. Ubomba Yaswa. You can give us your presentation. Thank you.
Research manager with the Water Research Commission. I manage a portfolio of projects around water resource quality and management, and in that portfolio is a thematic area around water quality and health, and we fund projects around WASH in that theme. So today I'm going to give a brief presentation around WASH infrastructure and access, and specifically looking at integrating climate resilience into WASH. So I thought I would start off by explaining what the Water Research Commission is, just in case we do have listeners who do not know what the WRC is or have heard of the WRC. So that WRC was established in 1971 based on the Water Research Act, and the overarching aim of that act is to ensure that water is used sustainably and efficiently, and also it's distributed equitably. So it's quite a unique model where you have a national research agency which is solely dedicated to water. How we get funds for the WRC is through a water research levy that every water user pays. When it comes to the funding that we do give, we fund about 50% of water research that occurs nationally. And then in the agriculture sector, we fund about 70% of that research. So although our primary function is to stimulate and fund water research according to priorities, we do engage in activities before we fund, as well as activities after we have funded the research as well. So we promote and coordinate cooperation as well as communication in the areas of water research. We do establish what water research needs are and priorities, obviously sharing that with our key stakeholders. Then once research has been completed, we promote the effective transfer of any information that's been generated, as well as technology that has come from the research that we funded. Then we also ensure that knowledge is enhanced in the sector in general, and then we also build capacity within the water sector. We do have a strong pipeline of students that we fund in academic institutions as well. So I thought it would be good to start off with what the WASH situation currently is globally. We have 2.2 billion people who don't have access to safe and managed drinking water services. That number increases to 4.2 billion people who do not have safely managed sanitation services. And when it comes to hygiene components of WASH, we have 3 billion that lack basic hand washing facilities. Localizing those statistics that I've just shared with you, the WRC was recently tasked with trying to find out the source of cholera outbreak that happened in Hammanskraal. Hammanskraal is in the city of Tshwane municipality. It's an area of about 8 kilometers squared with a population of about 120,000 people. It has different areas within it. So it has an urban component, a township, rural, as well as an informal component. And in our investigation, we had to track and identify the water sources and storage facilities, as well as sanitation facilities within that small area. And what we found, I think, is quite reflective of what is happening globally in different parts of the world, basically. So you had areas in Hammanskraal that were receiving water from a water treatment plant, and this was mainly being supplied to the urban areas where they would have taps in-house. Then you had those who were getting water directly from tankers. So because they were getting waters from tankers, in emergency situations, they were storing water in buckets as well as polycan drums and JoJo tanks for emergency purposes. Then you had those in the township and informal areas who were getting water directly from bottled water directly from retail stores. So in that instance, tracking where that bottled water came from was quite difficult. Then you also had those who had their own boreholes that had been drilled, and they were getting groundwater through that as well. And in those areas too, people were storing water in buckets as well as drums and tanks for emergency. Then when it comes to the sanitation and hygiene facilities, there's also complexity in that. There are about 6 different types. There were flush toilets in the main house, usually in urban areas, which had a wash basin as well in the toilet room in the main dwelling. You had outside flush toilets that did not have any wash basins associated with them, and mostly, unfortunately, were in a poor condition where they were detached already from the toilet wall. Then you had those who were using pit latrines, usually in the informal and rural areas, with no hand washing facilities located close to that pit latrine. Then we also had chemical toilets, where in those cases there was hardly any hand washing facilities for most households with those chemical toilets. Then you had flush toilets, which were connected not to a sewage, but connected to a septic tank, and those had limited indoor wash basins as well. So the effects of extreme weather events or climate change on our wash infrastructure and access is really as a result of high temperature as well as low rainfall. So in those cases, you have water sources drying up, you have a loss of your water supply. You also have an increased demand of water, because obviously it's hot. Then because of higher sea levels that are experienced, you do get saltwater intrusion as well, especially those who might be using groundwater. So the groundwater quality is compromised then. And then because of the temperature, you do get an increase of growth of some pathogens, as well as the occurrence of harmful algal blooms in source water. So thereby your source water is compromised in that situation. When you have flooding, you have contamination of water sources due to waste as well as sediment runoff. You have then physical damage of your water sources as well, or your sanitation facilities, especially when it comes to blockage of storm water. That is something that is picked up a lot during flooding. Then you also have increase in cost of treatment, because you now have a lot of waste runoff as well as sediment runoff entering into your source water supply. Another effect of climate change as well as extreme weather events is the result of fires on water quality. And I think this is something that needs more research, but I thought it was quite important to bring it into this presentation. So you do have ash that settles on water sources, so your streams, lakes, and I think of particular importance is the fact that a lot of strategic water source areas or water sheds are often forested, and those are highly susceptible to fires as well. So what are some of the steps, and these are few that can be used to integrate climate resilience into WASH? So in terms of current infrastructure, we can look at changing our maintenance schedules, including adaptive management to account for uncertainty in the future, and also building in nature-based solutions. I think this is something that has come to the forefront in mixing grey infrastructure with our nature-based infrastructure as well. For new infrastructure, it's an opportunity to already climate-proof new large water supply programs, to use digital technology such as remote sensing to identify areas which would experience extreme weather events, and to ensure that WASH infrastructure is not built there, or to help to identify, for instance, using remote sensing where you could possibly drill boreholes that would be able to supply water for longer periods of time. Financing programs that consider climate resilience is also key when thinking about new infrastructure. And the new infrastructure itself should also make sure that it is not contributing to climate change as well. Then water safety plans as tools to manage future climate risks is also something that has been looked at in various countries. Unfortunately, in our lower middle income countries, it's not really been explored as much, but it could be something that can be used to identify where there is a possibility to change guidance, as well as to also provide evidence where the integration of climate resilience has to come into when it comes to providing safe water. Then another key issue is to ensure that there is a way to measure progress, or frameworks that are designed to ensure that the climate resilience that we want to achieve in WASH is being achieved. So there are multiple possible metrics for doing this, but it's important that nationally these are identified. So with that, I would just like to thank you for listening, and I look forward to contributing to the panel today. Thank you.
Thank you very much, Dr. Yaswa. Once more, I'd just like to encourage you, ladies and gentlemen, just to use the chat group for questions, and also we will also communicate when we go into the panel session, into the panel discussion. Finally, I'd like to introduce Dr. Christopher Lebowa from the University of California, Berkeley. He is an environmental health scientist and in the UCLA Berkeley Institute, and his work focuses mainly on identifying pathogens in the environment and building systems for mitigating these exposures. Welcome, Chris, and we are ready for your presentation. Thank you.
My name is Christopher Lebow, and today I will be talking about how environmental surveillance can be used as a tool for identifying waterborne diseases, and how public health campaigns are utilizing environmental surveillance today. So 75% of the world's most burdensome infectious diseases are environmentally mediated, meaning that they spend some portion of their life cycle in the environment. And we also know from the different talks today how climate change alters disease dynamics, making different people at different times become infected than they would otherwise. And classically, public health surveillance techniques are either hospital-based, meaning that when people come into a hospital and they're very sick, they end up in a database showing a number of cases, or are community-based, meaning that enumerators will go out to people's homes and collect data to see if people are sick or not. Hospital-based surveillance techniques really only gather information about the most sick people and not everybody that's getting sick with the disease. And community-based disease surveillance mechanisms are extremely expensive, or people do not necessarily want to participate. Environmental surveillance offers a low-cost option for determining if a disease is circulating at all in a population. And there are three main ways that environmental surveillance has been used in public health to date. The first way is to understand the relative disease incidence. So during COVID-19 pandemic especially, sewage surveillance was used across the United States and across the world to understand where the disease was occurring and how many people were becoming infected. So using sewage surveillance with COVID-19, it allowed public health officials to have a lead time to the number of cases that were showing up in an area, and also ID new variants. The CDC has established a national sewage monitoring system with over 1,000 sites across the United States looking at sewage on a weekly basis. And by the number of sites that have detected positive in the last week, they can determine if COVID is waxing or waning across the country. The second way that environmental surveillance is used in public health today is for looking at the effectiveness of disease eradication campaigns. So with polio, there's been an effective vaccine for more than the last 50 years, and there are very few cases left. And looking at polio paralysis, this is a very rare condition. And so oftentimes public health campaigns will not necessarily be able to detect when polio is circulating in an area. However, water surveillance is now used to determine if there is polio in a geographic area. And when the water surveillance detects polio in an area, public health officials can use that information to target additional vaccination efforts. The third way that environmental surveillance is used in public health today is for determining disease transmission pathways. A single infectious disease can have multiple different transmission pathways. Something that's fecal-orally transmitted can be primarily transmitted through contaminated drinking water or surface water or contaminated food. And depending on the different geographies that you're in, there can be different dominant transmission pathways. And so to determine the relevant route of transmission area, environmental surveillance can be used to test those different potential reservoirs of the disease and determine if people are becoming infected through that route of transmission. And so I'll be going into a case study of our work on enteric fever in Nepal to show how we were able to use environmental surveillance to look at different potential transmission pathways of disease. So enteric fever is a fecal-oral transmitted disease, and it is spread through contaminated food or water, but how it is spread is different depending on different geographies that someone is in. And Nepal has a high incidence of enteric fever, with more than 330 cases per 100,000 person years. And prior work had shown there to be evidence of contamination of Kathmandu's aquifers. Those are the aquifers below the capital city in which people were getting their drinking water from through these stone spouts that have provided water for the last many hundreds of years. Work had shown that 77% of water samples that were taken from these spouts tested positive for Salmonella typhi and 70% tested positive for Salmonella paratyphi A. But due to climate change, urbanization, and an earthquake in 2015, the majority of these stone spouts no longer work, but people are still getting sick with typhoid fever. That leads us to ask the question, how are people still getting sick with typhoid fever? And brought us to the use of environmental surveillance as a tool for trying to determine that relevant route of transmission. So what we did first was we collected 370 drinking water samples from households both in Kathmandu as well as in the Kavri district, a more rural district outside of Kathmandu. And we expected a large number of these samples to test positive for Salmonella typhi and paratyphi A, following in line with previous literature. However, what we saw is that only 7 of the 370 samples tested positive for Salmonella typhi, and 4 of the 370 samples tested positive for Salmonella paratyphi A. It just thus indicating that this type of exposure was probably not the dominant route of transmission in this area. It brought us back to the drawing board, really, of if people were not necessarily getting sick by drinking contaminated water, how were people becoming exposed to Salmonella typhi and paratyphi A? And looking back in literature, in the 1980s, there was work done in Santiago, Chile, where there were high rates of typhoid fever infection, in which scientists were able to detect Salmonella typhi within the water bodies, within the rivers that went through the capital city and alongside agricultural fields downstream of the capital. And so the government instituted policy making it so that growers could not grow lettuce and other vegetables that were eaten raw downstream of Santiago. And in the following year, the rate of Salmonella typhi in the capital city was greatly reduced. The geography of the Kathmandu Valley is similar to Santiago in that there are 4 major rivers that come together within Kathmandu on the left of the screen and then go together in one single river downstream of the city. What we did is that we took 20 sampling trips at these 19 different sampling sites, both upstream of Kathmandu, within the city center, and downstream, to try to understand the rates of contamination of river water with Salmonella typhi and paratyphi A, to see if this type of water sample was what was driving transmission in this region. With each water sample, we split the sample, taking 5 milliliters to test the turbidity and to look at E. coli coliforms, an overall amount of fecal contamination of the water, as well as we took the other 45 milliliters of the sample and performed enrichment PCR. What this process is that we didn't want to just take a PCR sample, because if you just detect DNA, in this case, in your sample, that doesn't mean that the DNA is a risk to human health. It doesn't necessarily mean that there is a viable bacteria there that someone could get sick by. But by doing an incubation period in a liquid medium, we were able to grow the sample during that 16-hour incubation period and then do another DNA extraction after 16 hours and see if there was more bacteria in the sample after 16 hours, thus indicating that the bacteria was viable and a risk to human health. What we found is that 45% of samples tested positive for Salmonella typhi DNA, and 40% of samples tested positive for Salmonella paratyphi DNA. And almost all of the samples that tested positive contained potentially viable Salmonella typhi and paratyphi. And what we saw is that samples were not often positive upstream of the capital city, but within the city center and downstream of the city, samples were often positive. Up to 10 kilometers downstream, samples were positive more than 50% of the time that we sampled in those locations. What we saw was that there is a potential seasonality of the disease or of the sample positivity in this area. If you look at the B part of this graph, you see that rainfall peaks during July and August, the monsoon season. But if you look at portion A of the graph, you can see that the coliform levels decrease during this monsoon season, as well as if you look at section C of the graph, you see that during July and September, there is a reduced rate of locations that test positive for Salmonella typhi and paratyphi A. We don't have data in August because of COVID-19 lockdowns in this period. This indicates there's potentially a dilution effect of, as there's more rainfall in these rivers, there is just a lower proportion of the water that is sewage. We also wanted to understand how humans might be coming into contact with the river systems. What we saw is that along the rivers, people were washing produce at 2 of the different sites to be sold in nearby markets. There were also agricultural fields in which people were taking water from wells nearby the river at 11 of the sites in which we collected data from. We saw that people bathed in 4 different sites and people washed clothes at 7 of the different sites. And also at half of the locations, people walked across the rivers trying to get from one side to the other, moving animals. So what we see is that environmental surveillance offers tools for determining the disease presence in an area. It also allows public health officials to target campaigns for increased vaccination or increased medication, depending on the disease in question. And also environmental surveillance allows researchers to specify the transmission pathways of a disease through an area. And one crucial component of environmental surveillance today is that there's a limitation in the relationship between when a sample tests positive and what that connotes as a risk to human health. And more work needs to be done in order to determine when an environmental sample tests positive, what does that mean for the risk to the local population around that sampling location? And so if you have any additional questions, I will be on the panel for the next few minutes and would be happy to answer them. Thank you so much for taking the time to talk with me today.
Thank you very much, ladies and gentlemen. And this brings us to the end of our presentations from our distinguished presenters. We would like to thank Dr. Stephen Lobi. We want to thank Dr. Christina Moe, Dr. Eunice Ubomba Yaswa, and Christopher Leboa. I just want to find out, ladies and gentlemen, and to our presenters, maybe the first question is, what is to be done, and perhaps delve more into why is it that waterborne diseases such as cholera, for example, have got more voice than what we would find to be the case with typhi. And so I'll just give 1 minute to each of you just to really elaborate in terms of in relation to the presentation that you've given. Thank you.
Well, I would just say that I think typhi has a less dramatic presentation than cholera. And most of the time it is not culture confirmed. So I think that there's a lot of typhoid out there that is not recognized or is diagnosed as something else. It's one of the reasons why we don't appreciate it as much.
Thank you. Thanks, Chris. Thanks, Steve. Christina?
Thank you, Jennifer. I agree with Dr. Luby. I also think another major difference is that cholera can also kill a lot of adults. Whereas in typhoid fever, I think that most of the mortality now is among children. So when there's an outbreak of cholera and adults are dying, I think that captures more attention, unfortunately. Thank you.
Thank you for that. Eunice, perhaps maybe you can weigh in a little bit on water use and water reuse. I mean, we are moving towards talking more of saying, you know, we need to look at water such as used water, but from the presentations, I think looking at the infrastructure, there seems to be an influence that could come from there. And what is your view on that?
Yeah, I think that's where probably the water safety plans come in a lot. Because from the 4 presentations, there is the need to move towards water reuse, because we do know, I think Dr. Luby's presentation showed that the amount of available water is actually reducing. So there is a need to move into the space of reuse. But then that being said, that's where making sure that you're picking up the pathogens using water safety plans really comes in. And I think Dr. Mo's example was really brilliant in showing how typhoid was coming from the irrigation water that was being used rather than drinking water that people are using. So if we think about water safety plans, we think about reuse, we also have to really think about the One Health approach, which will then factor in all these types of uses, integrate even, we've not even touched on our animal watering and so forth, which also has an effect on some of our waterborne diseases as well. So I think definitely the focus has to be on water safety planning and taking into account what water source you're starting off with, and ensuring that you are identifying the appropriate risks with the water that you're using.
Thank you very much for that, Eunice. Chris, what would you think should be prioritized when we're looking at low, medium income countries? I mean, what is to be done in your view?
I think that there needs to be a higher level of equity in terms of who designs what needs to be done in low and middle income countries. I'm calling in from California, and I think that I see my own role as helping try to answer questions that governments and people in low and middle income countries have. And these solutions need to be driven not from the global north stating this is what is necessary for having clean water, but really need to be driven by governments and organizations in low and middle income countries. And given like the histories of colonialism and like vast power inequities in the global systems in which we work, they need support from global organizations. But I think that to have actual effects in getting systems of water across countries, those systems need to have the buy-in of people in those locations.
Thank you very much, Chris. Dr. Luby, there's a question for you. Do you think that the United Nations, where is it now? I just had the questions now. It just disappeared. But maybe just in 1 minute before we get to the questions, can I just ask each one of you just to give a reflection in terms of, you know, what you couldn't say in the allocated time in terms of this issue, particularly with focus around the climate funding. We know that countries are now really going into this SDG 30s, into this climate funding, but really is water quality and health, and as Eunice referred to it, One Health. Does the issue around climate funding even take into consideration some of these issues that we have mentioned? We can start with you, Chris, and then we can go back and end with you, Steve.
Yeah, I think that with the question of climate change and health, the idea of what would create resilient systems and how do we build insurance for disasters that are already occurring and that will continue to occur is a crucial component of what our ability to adapt in the next coming century is about. I thought that from Dr. Mo's presentation, the question of floodwaters and how often people were becoming into contact with fecal oral coliforms or through floodwaters is a really important component when we think about, like, just this week, there's in Los Angeles, not too far from me, there's an entire stadium that's surrounded in water right now. And climate change is going to increase rainfall, and just how do we think about when there are potentially contaminated water coming into contact with people and affecting people's water supplies? What are the solutions that governments can have, and what are the systems that can be in place so that people know how to keep themselves safe when they come into contact with potentially contaminated water?
Thank you very much. Noting, Christine, from your side, noting that wastewater reuse and street food provide many livelihoods. What is your view regarding education, training, and awareness? Is there really broad awareness around people that utilize this form of economy, and especially in the low, medium, and income countries?
Thank you. And thank you for that question. It's a good question, because we know that wastewater reuse is very widespread. So we need to think about how can wastewater be reused safely, because it's a precious resource, as Dr. Yunus pointed out. But I think that there are ways to be strategic about how wastewater is reused. Does it need to be used on crops like lettuce, things that are eaten raw, which is high risk? Maybe it's more strategic to reuse wastewater for other types of crops, something that is maybe like groundnuts or potatoes. So different types of food crops is one thing to consider. With street food, we know that street food is important for many poor communities around the world, but I think that better hygiene is critical. And so street food vendors could receive hygiene education, they could receive certification so that the customers will have greater confidence in their products. So I think all of these have solutions, but we need to be innovative and creative and persistent. Thank you.
Thank you very much. Stephen, Dr. Stephen Luby, do you think the United Nations SDG 6 to ensure universal access to water and sanitation, it will be achievable given the presentation that you're given, where you have shown that water availability per capita decreases year on year?
Yeah, I think that my view is that the Sustainable Development Goals are aspirational rather than roadmaps. We're also supposed to eliminate poverty by 2030. I mean, we have 7 years. We have worsening climate change. We have decrease in per capita water availability. I don't think we can achieve this by 2030. But as all of the speakers have pointed out, there are steps we can take to improve drinking water quality. And with water sanitation plans, we can improve the environment. And I think the efforts to continue to work to improve that in constrained settings and to monitor this globally are useful steps to continue to try to address some of the inequity that Chris referred to.
Thank you very much. Lastly, Eunice, from your side, coming from South Africa and reporting from South Africa, what is the level of education and awareness? I think you also mentioned around vaccination, but I think that none of you really elevated that part to say it's one a case where can be treated through vaccination. Can you weigh in on that just before we close the session? Thank you.
Yeah, I think for typhoid, that's a great example where vaccination programs work well. It's not necessarily so for every waterborne disease, but what is also really important is community engagement at a very local level to get the buy-in to use to even implement different wash practices, but also the different things that can protect them from preventable waterborne diseases such as vaccination programs. And then also coming back to resilient healthcare systems, that is also key. Because if there is, for instance, an outbreak, you would expect your health sector to really lead in front when it comes to trying to curb the outbreak as soon as possible. So they also, the burden lies on them with regard to messaging around vaccination as well. But I think for the waterborne diseases, typhoid is a great example where vaccination actually works.
Thank you very much. I would like to thank you, ladies and gentlemen, for the presentations. I think this was very insightful. Also to thank our audience that are online and the questions that have been raised. A recording of this session will be available in the next few days also on the World Water Week, but also under the Coalition Against Typhoid website. I would like to thank you, the presenters, for really opening our eyes into this silent waterborne disease. And I also hope that we all keep this dialogue moving. We can conclude this, and thank you very much for sticking around at this time of the evening here in Stockholm and everywhere you are. Thank you very much and good night. Bye-bye.
Bye-bye. Thank you.